Hello, everyone. Welcome, and thank you for listening to our pre-recorded CE on erythropoietin stimulating agents use, restriction policy, and pharmacy managed clinical practice agreement. My name is Susie Jing, and I'm a clinical pharmacy manager for oncology and infusion at OHSU. My co-presenters include Sheila McCollum, who serves as the medical oncology clinical pharmacy supervisor, and Gary Karagodsky, who serves as a ambulatory consults and infusion pharmacists at OHSU. We have no conflicts of interest to disclose. And we'd like to start with reviewing our objectives. Hopefully by the end of this CE, you'll be able to describe the role of clinical pharmacy agreement and/or collaborative drug therapy management policy as defined by the Oregon Board of Pharmacy. You'll be able to describe the background rationale for OHSU ESA use restriction and dosing policy in the ambulatory setting, illustrate the process of the OHSU ESA use restriction dosing policy, analyze ESA appropriateness based on labs and clinical findings as described in the clinical pharmacy agreement. We have 4 pre-assessment questions, starting with, what is the primary purpose of CMS National Coverage Determination? A, to provide individual doctors with detailed treatment guidelines for rare diseases. B, to establish nationwide rules on whether Medicare will cover specific medical services, procedures, or technologies. C, to set pricing and reimbursement rates for all medications under Medicare. D, to approve new drugs for market use in the U.S. For our second question, which is the following is a true statement about the safety warnings for epoetin alpha. Epogen should be used to keep hemoglobin levels above 12 grams per deciliter in all patients. Epogen is safe to use in cancer patients receiving chemotherapy with the goal of curing their cancer. C, Epogen should be used at the lowest level and dose needed to reduce blood transfusions and is not recommended for cancer patients getting curative chemotherapy. D, blood clot prevention is not needed when Epogen is used before surgery. Next slide. According to erythropoietin stimulating agent manufacturing labeling, when should a patient receive iron therapy? A, only if ferritin and TSAT are low, if ferritin is less than 100 microgram per liter or TSAT is less than 20%. C, only if TSAT is less than 20%. D, if ferritin is more than 100 microgram per liter and TSAT is more than 20%. Next slide. Our final pre-assessment question, what is the main difference between absolute iron deficiency and functional iron deficiency? Is it A, absolute iron deficiency means low iron stores, while functional iron deficiency means iron stores are normal, but iron is not available for use? Is it B, absolute iron deficiency means iron is present but not stored, while functional iron deficiency means iron stores are low? C, both absolute and functional iron deficiency mean the same thing, low iron stores in the body? Or is it D, functional iron deficiency means iron stores are depleted when absolute iron deficiency means iron is stored but unavailable? Next slide. The Oregon Board of Pharmacy allows pharmacists to participate in collaborative drug therapy management and protocols and clinical pharmacy agreements, primarily to help the practice advancements for pharmacists to support our licensed practitioners without direct oversight. At OHSU, the Department of Pharmacy has both CDTM protocols and CPA protocols. There are many benefits of CDTMs and CPAs, and that's the way that I will refer to them throughout the rest of this presentation. Pharmacists generally have the authority to engage in these privileges to improve measurable outcomes. Some of these outcomes include compliance with complex contracts for reimbursement, such as through Center for Medicare and Medicaid Services. It helps to improve safety by following toxicity outcome profiles, by lessening acute care needs, such as emergency room visits, by seeing patients in a more timely fashion, or in visits outside of a clinical provider. And lastly, they may improve the provider-patient ratio by pharmacists participating in disease state management, where pharmacists are able to take on clinic visits without having to schedule on top of the additional provider visits to help with medical management of some of the disease state-specific drugs. Next slide. There are many differences in between what a CDTM offers as compared to a clinical pharmacy agreement. Sometimes they are confused to be referencing each other, but they are two distinct entities. Traditionally, by the definition from the Board of Pharmacy, the Collaborative Drug Therapy Management Protocol really is limited to drug therapy management with guidance on specific dosing, frequency, duration, and route of administration. Whereas when you have a clinical pharmacy agreement, it actually permits that pharmacist to engage in the practice of clinical pharmacy for the benefit of that patient. In regards to our erythropoietin stimulating protocol, we do have this as a clinical pharmacy agreement in which our pharmacists are able to a broader range of medical management in terms of helping to manage their anemia. In terms of our CDTM in regards to the sponsor, it's typically for a agreement, collaborative agreement that is between a single pharmacist or practitioner or by a single organized medical group. And that is pretty similar in regards to a CPA as well, in which you have a pharmacist. However, it's also with a healthcare organization or within a physician in particular. When a CDTM is initiated, it actually requires a prescription to be generated for an individual patient that has all of the required elements that you would need to have as a part of a prescription order. So that would include patient information, drug therapy instructions, and the protocol that goes with the specific prescription order, as well as the prescriber authorizing it. The difference in the CPA is that once you have this agreement established, it permits the pharmacist to really engage in anything that's outlined in the actual agreement itself, which can be a multitude outside of a single prescription. Some of the examples that we have at OHSU that are collaborative drug therapy management protocols or protocols include tacrolimus, cyclosporin, immunosuppression agents to help with management of prevention of acute GVHD. And then on the other side, we do have clinical pharmacy agreements to help support anemia management and dosing and protocol in the ambulatory environment, which includes ESA and also IVIG dosing due to this wide variety of medical disease state indications. Next slide. So we have quite a bit of experience in ESA management across our institution. This started back in 2017 when we were informed of a significant number of Medicare claims for both ESA and IVIG therapies that were identified as non-submitted claims due to lack of provider visit documentation or not being able to meet the laboratory requirements. We estimated about $20,000 to $40,000 per month that was being uncaptured. And we did take the time to really kind of dig into the why behind the lack of being able to receive or submit for reimbursement. And we've identified a significant clinical practice gap in terms of what the providers were documenting, labs that were not being drawn or being drawn inappropriately. And we are missing a lot of the stringent CMS requirements that is necessary for cost reimbursement. And so starting in 2018, we have had a significant decrease in the number of non-captured agents. or non-captured treatments, and we've continued to be quite compliant with ensuring that we meet the CMS medical needs. And that will be detailed in many of the remainder of this presentation. Next slide. And now I'll go ahead and hand it over to Sheila McCollum.
Thank you, Susie. Now I'll be transitioning into getting into some of the details that are behind our ESA CPA. At OHSU Pharmacy, we have oversight of the ESA use restriction policy and clinical pharmacy agreement for pharmacy managed dosing. These are the foundation of our efforts to meet the clinical and financial challenges we face in providing treatment with these agents in the ambulatory setting. These challenges include high cost, emerging safety concerns, overutilization, despite this resulting in non-payable claims and write-offs. Pharmacy has been tasked with oversight, and the use restriction policy was instrumental in establishing the expectations and responsibilities around use. The CPA is an added benefit. With provider delegation, it allows our pharmacists to initiate treatment and make dose adjustments, as well as hold doses based on clinical monitoring that is detailed within the protocols. But first, let's take a step back and orient to these medications. Erythropoietin stimulating agents refer to recombinant analogs of erythropoietin. Erythropoietin is a glycoprotein hormone that's produced by kidneys in response to hypoxia, or indirectly from low hemoglobin levels. And this is then stimulating red blood cell production. There are multiple formulations of ESA available. Epoetin alpha is our reference product, and it's licensed both as Procrit and Epogen. And then we have our biosimilar Retacrit. We also have darbepoetin. There's also another long-acting ESA that's not on OHSU formulary called Mircera that you see in the dialysis setting. These ESAs work to induce erythropoiesis through mimicking the action of the endogenous erythropoietin. Receptors are found on erythroid progenitor cells, and activation leads to division and differentiation of those progenitor cells. Erythropoiesis is also an iron-dependent physiological process. Optimizing iron status is instrumental then to optimizing our ESA treatment. Thus, the ferritin and TSAT monitoring in our treatment plans. ESA given in the absence of sufficient iron stores for hemoglobin production results in the production of functionally immature reticulocytes, ultimately defeating the purpose. There are 4 FDA-approved indications for epoetin, but just 2 for darbepoetin, which is just to note that both agents do not carry all the indications. For off-label use, we have symptomatic anemia due to low-risk MDS, and CCN guidelines recommend, and it's widely an accepted use, but it's very important for us to make sure we're meeting that guideline recommendation of the 2A evidence level. Similarly, there's a role for anemia management of those who do not accept red blood cell transfusion, but these are off-label and largely not a covered indication for Medicare. So we're adding all these layers of consideration. You know, what's the patient's iron status? Is the agent indicated for the treatment? Overall, it seems like it could be straightforward, but as we get these layers, it becomes more complicated, and thus our use restriction policy. And let's take a deeper, now we're going to transition into taking a deeper dive into a timeline of how we got here. So let's go back to the beginning. The FDA approved epoetin alpha in 1989, and the indication was expanded in 1993, and then darbepoetin came along in the market in the early 2000s. At the time, these medications were being used broadly for anemia, and the general practice was to push to normophysiological hemoglobin or hematocrit levels. But post-marketing data began to demonstrate the risks, We get into the details of these studies a little bit later on in this presentation, but the risks included cancer progression, increased mortality, and increased cardiovascular events. In 2007, the first black box warning was presented by the FDA to address this, where we saw a restriction of hemoglobin less than 12 as the standard practice of what we would not treat up to. And this was a shift to treating now to a hemoglobin target range. The same year, CMS started to work on our National Coverage Determination for ESA. The 2007 mark was basically a real pivotal moment for ESAs. They were the highest drug expenditure for Medicare. They had all this data emerging for adverse drug events and serious effects, and then our black box warnings for strengthening. But despite all this, there was an investigative report from the New York Times that detailed drug manufacturers giving huge financial incentives to providers to basically maintain the status quo of prescribing to normal physiological levels and for all sorts of indications. But studies continued to come out demonstrating these adverse drug effects and risks. Practice was really slow to change. So then in 2010, a REMS program was initiated that was put out through the FDA in action in 2011 to ensure that benefit was greater than the risk for patients. And it really helped to require provider and patient education on these medications. And then in 2011, they also strengthened their black box warning. And this is when we saw the emphasizing of a target of less than or equal to 11 grams per deciliter in our chronic kidney disease population. And when pushing that over the risks of death and serious adverse cardiovascular events, our higher tumor rate, progression, and recurrence, these were all then highlighted in our black box warnings. And this is also when we saw a paradigm shift again, where we were no longer targeting a hemoglobin range as our goal of treatment, but instead using the lowest dose possible to avoid transfusion. In 2017, our REMS program was eliminated, and that was then removal of oversight for appropriate use. And it put the onus back on the providers. And in 2018, Noridian, which is our local coverage determination at the time, they retired that local coverage determination. And so all billable claims then began to default back to the Medicare National Coverage Determination from the standard set in 2007. This basically removed all guardrails that were in place, and we then saw an increase in non-billable claims, which led to our 2020 OHSU use restriction policy. So the first big takeaway of the Medicare NCD is that it outlines coverage benefits for Medicare patients, and so has significant impact on our practices. Of note, it was drafted in 2007 and implemented in 2008. And since then, there have been a few updates. The National Coverage Determination details dose considerations for ESA use, and then it specifically calls out non-covered indications that would effectively mean that an ESA is not covered, even if there is a concomitant covered indication. Anything outside of these parameters would be considered a non-billable claim and would need to follow a process outlined in our policy for appeal. It helps to know what a national coverage determination is anyway. So a national coverage determination is a policy or decision made by the Center for Medicare and Medicaid Services regarding whether Medicare will cover a specific item or service. And this is made through an evidence-based process with opportunities for public participation. Operational administration for traditional Medicare is facilitated through these private health insurers known as Medicare Administrative Contractors, or MACs. And for us, this is Noridian. We fall in jurisdiction JF. And you can see that the United States are split up into these jurisdictions. And these are the processors who bill for Medicare Part A and Part B. MACs can have the opportunity to implement local coverage determinations, and these are intended to fill gaps when there is an absence of national coverage determination, or if there's a real need for a national coverage determination clarification. So, despite these national coverage determinations and all of the changes in practice, it's also important to keep in mind that the cost associated with these medications remains very high. At a societal level, the annual excess costs associated with the ESA administration was estimated at $2.5 billion in the United States. And the majority of these were in clinic administration, and approximately 80% were Medicare issued patients. So it's really important for us to understand the NCD. The medications are complicated and they require direct monitoring. They're difficult for our providers in the ambulatory setting to manage without provider visit with each administration. And it's a huge demand on resources. So it's an opportunity for our pharmacists to ease that demand with our clinical pharmacy agreement. The second thing I want to point out is that the ultimate objective of the national coverage determination and our use restriction policy is to ensure clinical appropriateness of these medications. These agents are not without considerable risk. So how do we ensure that the benefit is outweighing the risk and incorporate these black box warnings into our practice? In doing so, though, it actually captures the requirements of the billable claims. So we're going to spend the next few slides exploring these black box warnings. First, we'll focus on chronic kidney disease. Patients are at a greater risk of cardiovascular disease and stroke when we're aggressively using ESAs to a goal of greater than 11. But also, no trial has really identified a target hemoglobin level where the risk is not increased. So our goal is to use the lowest ESA dose to reduce the need for red blood cell transfusion. Over the next few slides, we have summarized the clinical studies that are used to establish these black box warnings and current practice. And I'm not going to go over all of this in detail, but we want to have it provided to you here for your reference. And these slides, of course, are available to you at later time to review if you find utility in these details. But there are some key details I will point out. For anemia due to CKD, the studies behind the black box warning are the CREATE, CHOIR, and TREAT studies. CREATE initially set out with the hypothesis that treating to a higher hemoglobin level would actually have improved cardiovascular outcomes or even improve overall survival for these patients. And the background to really understand this is at the time, it was accepted that patients with anemia had a higher risk of adverse cardiovascular outcomes in general. But instead, researchers found the opposite to be true. The studies, they all use different agents, so that's important to point out. And all were multi-center studies. CREATE and CHOIR used elevated high group target arms versus lower hemoglobin goals. And TREAT, rather, was a placebo-controlled group, which is our only placebo-controlled study here. But they did allow rescue ESA doses. So they were essentially treating an aggressively treated arm versus a lower hemoglobin arm. The studies looked at various outcomes, but they were various composites of cardiovascular and survival outcomes. The study designs were similar. They were all intent to treat with follow-up in 2 to 3 years. Secondary outcomes reviewed included impacts on kidney function and quality of life. And it's worth noting that all patients in the TREAT trial had type 2 diabetes. All of the studies excluded patients with high cardiovascular risk and all had variable definitions of iron status at baseline. For results, these are just the highlights. CREATE demonstrated no cardiovascular benefit to pushing hemoglobin level, and also more patients moving to dialysis. And a high quality of life impact was seen, but only in the high hemoglobin arm, and that was not replicated in the CHOIR study. Cardiovascular risk became apparent with CHOIR and TREAT, and with TREAT, significant increase in the incidence of stroke was seen in the treatment arm, but we see here also that there was a lower transfusion burden in our treatment arm. None of these trials were without their weaknesses, and the results are difficult to interpret in terms of clinical generalizability and standard of care relevance in modern times. But the bottom line takeaways, the lesson or the lessons that we learned are that CREATE showed no clinical benefit to pushing hemoglobin levels. CHOIR actually showed no, there's a risk, and then TREAT confirmed that risk. And all demonstrated that the treatment groups had reduced substantial transfusion burden, giving us our actual clinical treatment goal for therapy, which is transfusion reduction. It's especially important goal for our patients being considered for kidney transplant. It's helpful to note that the quality of life findings here, because we do run into providers who will want to push hemoglobin for a quality of life benefit. And what these studies showed is that, yes, there is a quality of life benefit, but only at the hemoglobin levels we are not treating to because of safety risks. So now we'll move on to looking a little bit into this black box warning for the use in cancer, which highlights a shortened overall survival and increased risk of progression or recurrence. But again, highlighting that our goal is to use the lowest dose possible to avoid transfusion. So there are multiple studies backing this black box warning, and they're all summarized even just in the package insert for the medication. The outcomes have been replicated in multiple cancer types with different staging and with different backbone chemotherapy treatments. All of these studies aimed for aggressive hemoglobin targets, and many of these trials were stopped early at midpoint analysis. As a result, there is a limited role for ESA use in cancer, and thus the indication for anemia due to chemotherapy with palliative intent, specifically for non-myeloid cancers. Most recently, with improved blood donor donation tests and standards have even begun to a complete shift to treatment favoring transfusion support for myelosuppressive chemotherapy. And it really further narrowed the place for ESAs in this treatment area, and focusing then primarily on patients who are unable to receive transfusion or who have a higher transfusion burden due to ongoing chemotherapy treatment. And the final black box warning cautions the increased risk of DVT for patients receiving ESA for peri-surgery transfusion reduction. And it recommends DVT prophylaxis for these patients. So epoetin alpha is indicated for transfusion reduction following surgery. It's used very occasionally, and that's because it is only indicated for use in elective non-cardiac procedures. And again, where we see this primarily in practice is in patients who are unable to receive transfusion. And in these cases, DVT prophylaxis is recommended to be initiated post-operatively, and that is deferred to the referring surgical team. Okay, so now I want to move into some pearls and some information that's important to know in the context of all of these black box warnings and considerations. So ESAs have multiple effects that are thought to contribute to these risks. But it's really presented in a dose-dependent fashion, where higher doses of ESA equal a higher risk. And super physiological doses of ESA They can have off-target effects, as with any other medication. But there are other cell types that express these epoetin receptors, including our endothelial cells. And so cardiovascular and thromboembolic risk does not seem to be that surprising when we think about this. We see side effects that include hyperviscosity or intimal hyperplasia and hypertension. We also can see a reactive thrombocytosis that's attributed to ESA treatment, and that's been associated with our underlying iron deficiency. So again, another reason to optimize iron status before giving these treatments. These adverse drug effects are further complicated by resistance to the medication. In our patients with anemia to CKD, resistance has been demonstrated in about 10 to 20% of these patients, and that continues to necessitate higher doses, which then can lead to an increased risk of these toxicities. All of this is to circle back to the goal of using the lowest dose possible and sufficient to prevent transfusion, all while balancing this goal of preventing toxicity. How this shows up in our CPA. We have hold parameters for iron deficiency. We have hold parameters for uncontrolled hypertension. We have follow-up assessments for response. And we also have instructions for when to follow up with providers if a patient is not responding to treatment. Part of our CPA is a newer pharmacy-ordered intermittent iron protocol, specifically for our patients with anemia due to CKD. Before this protocol, when patients did not meet iron lab parameters, we were, being constantly pinged for like, what's next? What's next? So I want to spend my last few minutes with you reviewing some iron lab pearls. It's impossible to optimize our ESA dosing without also ensuring sufficient iron stores for erythropoiesis. One of the most common requests we get is to override the iron parameters in our ESA plans. Like our ferritin is greater than our 100, but the TSAT's less than 20%. And the provider just wants to know, can we override that and proceed today? But this parameter comes from the manufacturer labeling with which directs the iron should be given for a ferritin of less than 100 or a TSAT less than 20%. To this, we just also saw on the last slide that iron deficiency can play into the toxicities with ESAs, which includes our low TSAT. So it's important to understand then that ferritin indicates our iron stores within a cell, and that TSAT indicates the amount of iron that is immediately available in the circulation now for erythropoiesis. And when we're considering an ESA treatment, both are essential. We must have iron available now for red blood cell production, and then we need to have more to mobilize to meet that demand of ongoing treatment. You may have heard also that these have been called acute phase reactants. Ferritin is a positive acute phase reactant. This is where a lab value goes up because our iron is being sequestered within a cell. And TSAT is a negative acute phase reactant, meaning this goes down because, again, in these stages, iron is being sequestered within the cell and then stored in ferritin. During inflammation and infection, these processes mobilize iron stores. Mobilizing our iron stores into our blood from our cells are altered. And so what you see is that the body sequesters iron away. This is proposed to be an evolutionary mechanism to fight off infection, but where we see this in practice is with our patients with chronic disease, like chronic kidney disease. This is for your reference. It's a slide that reviews the basic physiology of iron in the body. And I'm not going to review the entire process, but I do want to focus on pointing out that hepcidin is our master iron regulator. It's stimulated by cytokines and increased plasma iron. Also by bacteria or pathogens and various other proteins. But ultimately, hepcidin affects the absorption and prevents iron stores from being released into circulation. And the takeaway I want to convey is that if ferritin is greater than 100, It is also important that the TSAT be greater than 20% and that we need regular monitoring to ensure that we're meeting the iron demands of erythropoiesis. Assessing iron status is not as simple as looking at the iron store and a ferritin of greater than 100. We also see a lot of iron deficiency in our anemia due to CKD patients, but they need intermittent doses. And our absolute iron deficiency is just one cause, but there's also many metabolic causes that require us to rethink how we maximize iron stores in these patients, including the ongoing use of ESA agents on their own. This visual helps to organize different possible scenarios. If providers asks for an override for iron stores to move forward with ESA, the short answer is no. And often that the patient should be considered for iron repletion first. Complex cases might arise, and if these do, please escalate those to our consult pharmacists or myself, supervisor. A couple notes, our upper limit of ferritin varies by guideline, and functional iron deficiency should be corrected with IV iron. Oral iron may be ineffective, and this is now taking us back to my mention of hepcidin, because where it inhibits that movement of iron, it also inhibits the absorption in the GI tract. So now I'm going to hand things over to Gary to dive into the specifics of our CPA and try some of this out with some patients.
Thank you, Sheila. All right, so now let's, next slide, please. So let's transition to taking a look at our ESA CPA in action. The first step is having the provider ordering a consult to clinical pharmacist order, as shown here. This consult order should be available within order entry if the provider is logged into an ambulatory context within their Epic. Next transition. During order entry, the consult order will require the provider to select the reason for consult, which in this case would be for ESA. The order then requires them to select an appropriate indication for that ESA, and this then subsequently populates further prompts where the provider must enter in details that our ambulatory consults team will use to see if they qualify to be included within our pharmacist managed dosing protocol if desired. Next transition. As shown here on the right, you can see that the variability we have between our allowed indications for ESA treatment. We currently have 5 indications that we have established protocols for our pharmacist managed dosing, and each has their own unique requirements that a patient needs to exhibit to qualify to be pharmacist managed. Next transition. Lastly, during intake of these orders, our ambulatory consults team will also ensure that iron studies are meeting parameters prior to treatment. Just to underline that all protocols are required to meet the iron study parameters of ferritin greater than 100 and TSAT of greater than or equal to 20%. This requirement stems from FDA labeling for appropriate use of these agents, and the 90-day requirement that is that we exhibit is extrapolated for how fast your body will philosophically replenish those iron stores, and also correlates to the time window that some of our commercial insurance plans will accept iron study results for authorization of treatment. It is for this reason also that we cannot override them if they are not met, for insurances are prone to writing off these claims when ESA is given outside of these iron studies parameters. So here is just a table for a side-to-side comparison of the different hemoglobin requirements for both our initiation and maintenance doses of ESAs by indication and specific agent. Likewise, the variable dosing intervals per indication are also shown. I do want to note that our CKD, post-renal transplant, and perioperative both also have a hematocrit requirement for initiation that could also affect decision to hold versus initiate treatment. Next slide. And here is pulled straight from our dosing policy, are just the different dosing levels utilized within our pharmacist managed dosing protocol, with darbepoetin on the left and epoetin on the right. You can see that the starting dose and range of dose used within the protocol is hinged upon the patient's starting weight at time of the consult. If a provider ever does desire to deviate from these dosings, we typically will require that patient to be opted out of our pharmacist dosing protocol. These slides the last two slides will be helpful in our upcoming case questions, so feel free to return to this slide during that part of our presentation or reference our supplemental materials as well. Next slide. Now, we know this protocol is pretty bulky and a bit intimidating, so within our policy 2, we have created a decision workflow for how to navigate through the pharmacist managed dosing protocol, which also can be found in MCN, and should be a very helpful tool for when you are in a situation where you are going through your order verification of these orders in our various infusion spaces at CHH and CHO. Next slide. And here, just want to touch on some frequently asked ESA questions that we receive to our ambulatory consults team. The first one is when to add on a GCSF. So this part within our protocol is exhibited only in our MDAS indication, where at week 12 post-initiation, if the patient still is not meeting that target range of 10 to 12 grams per deciliter within their hemoglobin, we have this option to add on GCF to kind of help boost the effectiveness of the ESA. There is some low quality evidence out there that kind of exhibits that it could increase the sensitivity of the body to these ESA agents while not really adding on any additional risk. So per the protocol, the hemoglobin increase has been less than 1.5 and the hemoglobin is still less than 10, and there is no decrease in transfusion noted. You can have the potential to add on this agent by checking in with the provider first. And we typically see this added on as just a filgrastim product of 300 micrograms given 1 to 3 times weekly. The second most frequently asked question is the timing between treatment and iron studies. So kind of mentioned earlier, but prior to initiation, our iron studies need to be obtained within that 90-day window. However, when we do come to those situations where we have some iron repletion that's done and we need to do some follow-up, our typical window for follow-up on post-iron repletion for these iron studies is a 7-day from last date of iron infusion. I do want to highlight, though, that within our intermittent iron repletion protocol that we have for our patients with anemia of CKD, there is a situation based on the type of iron deficiency within that protocol that sometimes you will see this follow-up window being 28 days later from last iron administration. Our next frequently asked question is dose adjustments for opt-out patients. So if you do notice a patient who is not being dosed by our pharmacy managed protocol and you kind of notice that their hemoglobin still is not reaching that goal despite maybe multiple treatments, that's kind of your clue then to maybe reach out to the provider to see if they want to take a closer look and make any adjustments to this therapy. While we're not necessarily charged with driving the dose for these patients for opt-out, there still are responsibility to kind of note maybe some clinical inefficiency with the current regimen they are on and kind of be that bridge to reach out to their provider to maybe get the ball moving on seeing if we can optimize this treatment somehow. Typically, it's done by just an inbox message to the provider, and if you really are finding that you are crunched for time, you could always forward this to our AM consults team that can kind of pick it up from there and do that follow-up needed to make sure that that patient's dosing is assessed. And lastly, the most frequently asked questions is, are these same-day labs and treatments okay? So just want to say for iron studies and ESA, next transition, they cannot be done on the same day. This kind of goes back with how these claims are all done retroactively through Medicare. And if they do have a potential of noticing that the same date of service, iron studies are obtained on the same day of service of the ESA injection, and that iron study result does not meet those parameters, then they will write off that claim. And fortunately, just by the time that these labs take to process, it's at least 24 to 48 hours before we can get these iron studies back. There's just no way that we would be able to capture that during the infusion encounter, that these studies aren't meeting it. So we do require our patients to come in at least a day or two before their appointment to get these iron studies done. And then for blood transfusion ESAs, this is okay. and will not affect any issue with clinical efficacy or potential for being prone to that treatment being written off by Medicare. Okay, next, we're moving on to our case questions. I do want to just say that some of these are a little more involved than maybe what you're used to in some of your CEs. So feel free to pause before we go on into explaining the answer for each case. Please refer back to our MCN policy, which we should also have available for you in the supplemental materials to kind of help you move through these cases. So for case number 1, we have GA presents to clinic today for their initial ESA injection. GA's treatment is opted into the pharmacist-managed dosing protocol for chronic kidney disease. So question 1 is, which of the following is a correct order to verify for GA? A is a darbepoetin 300 micrograms every 4 weeks. B, epoetin alpha 10,000 units every 3 weeks. C, darbepoetin 25 micrograms every 4 weeks. Or D, epoetin alpha 2,000 units every 4 weeks. A patient's vital is a BP of 145 over 87 millimeters mercury with a weight 57 kilograms, and pertinent lab values presented today are ferritin of 145, a TSAT percentage of 23%, and a hemoglobin of 8.8. So moving on then to the answer for case number 1, the answer here is C, darbepoetin 25 micrograms every 4 weeks. Options A and B are incorrect because the dose is not a starting dose used within our CKD protocol. And D is also incorrect because dosing interval is incorrect for epoetin for the CKD indication, which is every 2 weeks, not every 4. Moving on. So case number 1 continued. GA was given darbepoetin 25 micrograms as per protocol at his initial visit and returns for his next injection appointment 4 weeks later. Which of the following is the correct next dose per protocol? Is it A, to hold treatment and reinitiate treatment when HGB is less than 11 with darbepoetin 20 micrograms every 4 weeks? B, increase the dose to darbepoetin 40 micrograms every 4 weeks? C, decrease the dose to darbepoetin 20 micrograms every 4 weeks? Or D, increase the dose to darbepoetin 60 micrograms every 4 weeks, with today's vitals being a BP of 139 over 85, weights 58.1, and pertinent lab values, again, a ferritin 145, TSAT percentage of 23, and a hemoglobin of 10.1. So the answer for this case will be answer C. A is incorrect because the hemoglobin is not greater than 11, so the dose should not be held. And B and D are incorrect because 4-week trend has not increased greater than 1 gram per deciliter in the hemoglobin. So it should not be reduced and increased or increased. Okay, moving on to case 2. BB presents to clinic for their weekly epoetin alpha injection for MDS and is opted into the pharmacist-managed protocol. They previously were receiving a dose of 40,000 units weekly. What of the following is the correct course of action with their treatment? Is it A, hold treatment and reach out to provider regarding need for iron repletion? B, continue epoetin alpha 40,000 units weekly? C, increase the dose to 50,000 units weekly? Or D, decrease the dose to 30,000 units weekly? The previous visit, pertinent vitals and labs were blood pressure of 134 over 78 at 66 kilograms with a hemoglobin of 10.1 with the most recent ferritin of 109 and most recent TSAT of 23%. And at today's visit, their blood pressure is 144 over 81 millimeters mercury, a weight of 66.3 kilograms, a hemoglobin of 9.9 with the most recent ferritin of 45 and the most recent TSAT of 21%. Now moving to the answers for case 2, the answer is A. B, C, and D are all incorrect because while the dose for B would be correct per our protocol for what would be the next step in their treatment escalation, we need to acknowledge that the patient's ferritin is not meeting parameters. So we would hold treatment and reach out to provider regarding the need for iron repletion. So case 2 continued. BB completes a treatment for iron dextran 1,000 milligrams to replete their iron stores. What should BB return to clinic to have their follow-up studies drawn? Is it A, iron studies to be drawn same day prior to next ESA injection? B, iron studies to be drawn same day after the completion of iron dextran administration? C, iron studies to be drawn as early as 3 days after completion of iron dextran administration? Or D, iron studies to be drawn as early as 7 days after completion of iron dextran administration? And the answer here is D. As you can recall, I highlighted that iron studies should be drawn as early as 7 days after completion of iron dextran administration, or from when last iron was given. All right, moving on to case 3. JL presents to clinic for his next ESA injection appointment. Their treatment is being managed under the pharmacist managed dosing protocol for chronic kidney disease. His current dose is darbepoetin 60 micrograms every 4 weeks. However, his last treatment was held due to a hemoglobin of 11.4. Today's hemoglobin resulted to 10.1. Assuming that all pertinent vitals and laboratory values are meeting parameters, what is the appropriate course of action for JL's treatment? Is it A, hold treatment and resume at next follow-up when hemoglobin is less than 10? B, administer darbepoetin 40 micrograms every 4 weeks? C, administer darbepoetin 60 micrograms every 4 weeks? Or D, none of the above? All right, and the answer to case 3 is A is wrong because the threshold for restart should be less than 11. C is incorrect because since last hemoglobin was held for being too high, the treatment restart should be given at that -1 dose level that is exhibited on the protocol. And D is wrong also because option B is correct. We would go ahead and administer darbepoetin 40 micrograms every 4 weeks. So to wrap up, CPEA and CDTM policies by the Oregon Board of Pharmacy authorizes pharmacists to manage and adjust highly complex therapies to improve patient care outcomes and provide cost recovery. The OHSU ESA use restriction and dosing policy was implemented here at OHSU to ensure safe, effective, and appropriate use of ESAs in our outpatient settings while also minimizing risk like overuse and reduced potential ADEs. And standardization of this process creates clarity for all healthcare staff involved to optimize treatment outcomes and improve patient safety. And next is our references. And we would like to thank you for your time and attention. And please reach out for any other further questions you may have.